Welcome to SATA NCLEX. Chronic obstructive pulmonary disease, COPD, is guaranteed to show up on your NCLEX or NACE scoop. And if you understand air trapping, oxygen limit, blue bloaters, and pink puffers, you'll be able to answer COPD questions with confidence. In this video, I'm going to make COPD simple as much as possible, followed by 5 questions to analyze, to synthesize the information you've learned. Are you ready? Get ready. Let's go. First thing I want you to know is to define COPD. It's a chronic, ongoing, obstructive. That is the end of COPD. Obstruction is the main problem. Pulmonary, lung, disease, right? Remember, and pay attention specifically for this concept. There is no COPD patient who presents with only one problem. Most of them have combination, whether emphysema or bronchitis. But the prominent disease will show up as emphysema, but underlying problem, they still have a little bit of bronchitis. So we classify them based on the major symptoms, but most of them have a mixed symptoms. What is the cause of this? Number 1 is smoking and irritant. So any patient who has COPD, this is the area we target to prevent this problem. Otherwise, the mortality is going to increase. Overall, it's a progressive problem. That's why it's called chronic. And it's irreversible because there's something we call fibrosis, scar tissue of the lung. And that is the fibrosis leading to obstruction. Therefore, we cannot reverse this problem. This is why asthma is not a COPD, because asthma is reversible. By COPD, emphysema and bronchitis, the lung is destroyed by fibrosis. And therefore, all of them are characterized by air trapping, hyperinflation of the lung, eventually lead to impaired gas exchange. That's why they're always looking for oxygen due to dyspnea or cyanosis. Key, dyspnea and cyanosis. There's one who is always have cyanosis. That's bronchitis. And dyspnea, you see it in emphysema. So pay attention to the concept, and we're going to use to analyze everything. Let's get to it. Now, pathophysiology. I told you the blue bloaters is bronchitis, blue people. Why? The pathophysiology is the key. They have chronic inflammation of the bronchi. The bronchi has multiple inflammation. If this is the airway, you have the lung here like that. But remember, the little bronchi, these structures can have chronic inflammation. In the process, what is going to happen when you have inflammation? You're having mucus secretion, and this is what is the major problem. They have excessive mucus secretion. What is the mucus is going to do? It block the airway and make the wall very thicken and thicken and thicken. In the process of healing itself, it forms fibrosis, and these fibrosis lead to obstruction. That is the major problem with bronchitis. Inflammation leading to mucus production. The mucus production block the airway as a result of fibrosis. We don't have to know details about which cells are involved, but just know that inflammation, mucus production, thickening of the airway. That means fibrosis of the airway leading to obstruction. And therefore, if there is obstruction, they're going to have problem bringing air in or air out. But the major problem is not bringing in air. It's the problem of bringing air out. So most people with bronchitis or emphysema, they cannot get rid of the air aspiration, cannot get it out. In the process, think about it. Your lung is already full with air. How can you breathe on top of that? And that is the problem. They take them a long time. They struggle trying to put air on top of the lung that is filled. That is why emphysema patient have mostly dyspnea because their lung is huge compared to the bronchitis, and they can't take any more air on top of what they have. This is the pathophysiology of what? Bronchitis. Chronic inflammation, excessive mucus production, thickening of the airway, and then it leads to what? Obstruction. In the process, there is specific features you will see in them. Most of them, they'll come to you and say, I've been coughing for 3 months nonstop. Then you know that they have what? Bronchitis. That's the classic symptoms. What signs and symptoms are they going to show? Pay attention to this. This is a select or apply question. Number one is productive cough. They will have dyspnea like emphysema, but mostly productive cough. And since they are blue bloaters, they're usually cyanotic. They look blue, and they look blue. So pay attention. That is the key. And then with the secretion, there is more likely to be an infection of the thick secretion. And if you have secretion, you're going to wheeze because of obstruction, and you're going to have bronchitis. This is when you listen to them, major breath sound that you're going to hear is what? Wheezing and bronchitis. So additional information that you should pay attention to due to the hypoxia because of the dyspnea is going to stimulate the kidney. This one is pathophysiology. You have decreased oxygen. In the process, your kidney will see this as what? Hypoxia. It releases hypotension alpha, which go to the bone marrow. The bone marrow releases a bunch of red blood cells. In the process, your hematocrit go up. And this is consistent with chronic cyanosis leading to Polycythemia vera. They also have respiratory acidosis because of what? Retention of CO2. That is the major problem because I told you there's an obstruction, airway obstruction, trying to push the air out. In the process, they retain CO2 and they have respiratory acidosis. Know these signs and symptoms. Think about it. Don't memorize it. Use the pathophysiology like I've explained. Each of them, you can explain it based on the concept. Now, there's a difference between emphysema. Emphysema, remember, there's no mucus secretion, right? If this is the airway, there is something we call, or in the alveoli, these alveoli are something we call elastin. Elasticity, like something that can recoil. In emphysema, there's destruction of these cells, tissues, elastin, and therefore the lung cannot walk, keep open. It collapses in itself. And in the process, when you put too much air in, they become like bloaters. They're more bigger, alveoli bigger and bigger and bigger and bigger. It loses elasticity in terms of recoiling, decreased recoil. And that is the problem. And therefore, they have these big bullae, destruction of the alveoli. And therefore, they have a big lung compared to bronchitis. Think about it. If this is the lung already, how can you breathe on top of it? You can't breathe. And so they mostly have what? Dyspnea. And you have air that is trapping in the lung, and the lung become hyperinflated. Remember, we cannot recoil the air out. This is the lung with alveoli. Alveoli get bigger, and you cannot recoil and push the air out. When you try to breathe on top of it, you're trapping the air in the process of when you are expiring. And that is the problem. These therefore affect what? Gas exchange. Therefore, in the hand, what do you get? Alveolar collapses during exhalation, and you have barrel chest because you have too much air in your chest. You got to have a bigger chest to contain them. And that's the signs and symptoms you see. If you get an X-ray, most lung you're going to have at the diaphragm, it look like that. In these people, big lung and a flattened diaphragm because they need more room for air to contain. And then if the NCLEX does not give you flattening diaphragm or air trapping, they will give you AP diameter. That means anterior posterior diameter of the lung is bigger. because they trap in. That's why we call them pink puffers. They have too much air in their lung and they look pink. Therefore, what are they going to ask you? Manifestation. Like I said, due to air trapping, progressive dyspnea. They usually don't have cough. So when you see a cough, don't pick it. Pick what? Bronchitis. What we're going to do, these people are air trapping. So in the process of expiration, they're going to trap air. This is why we purse lip, so that we can prolong expiration. When you breathing in, you usually take you a long time to bring air in, then very short time to bring air out. So inspiration is greater than expiration. In emphysema patient, they air trapping. We don't want that. In the process, we're going to purse lip, like whistling, so that we can prolong our expiration greater than inspiration. And this is what you teach them. They're usually very thin. They are not that big like bronchitis. And they use the accessory muscle in order to push air out. They usually will be tachypnic. So these are little signs and symptoms I want you to know specifically. In the selected apply, you should be able to compare all of them together. And when you know them, the NCLEX become easy. Whatever questions they ask you is easy. So I give you a table. This table is designed to simplify everything for you. What is the main issue of bronchitis? Mucus production. Emphysema is due to alveoli cannot do its job. So it get destroyed because of lack of elastin. Cough, more common in bronchitis because of mucus secretion. In emphysema, minimum cough. So morning cough is not there. What is the body type? Emphysema patients are usually small compared to bronchitis patients. Cyanosis, mostly bronchitis. Emphysema, no, because they have a lot of oxygen, but they cannot get rid of it. Breath sound. When you listen to bronchitis, because of the fluid, the mucus, they sound ronchi and wheezing. Emphysema, why would emphysema patient have diminished breath sound? Think about it. If this is the airway, their lung is like that, very big. When you listen, minimal air you can go into listen. It's full of air, but there's no breath sound. When you listen, it's minimum because of the way they cannot exchange. So they have minimum breath sound, decreased breath sound. The AP diameter, anterior posterior diameter emphysema, because the lung is very big, is increased, and it's normal for these people, bronchitis. So know the difference and know how to deal with it. You see, in the case study, you have to know what to do, how to diagnose them. Everybody get a pulmonary function test. For the NCLEX and the nursing school, I don't think they're going to bother you about details of pulmonary function test. In the answer choice, pick pulmonary function test. Get an ABG. You're going to see what? Respiratory acidosis, chronic with bronchitis. And when you get a chest x-ray, hyperinflated lung and a flattened diaphragm in emphysema based on the pathophysiology I explained it to you. Now, you expect the NCLEX to ask you, what do? They will need oxygen. But do you think you need to blow them with oxygen? No. Very low flow. Sometimes 88% saturation is the best it can be. 91. You don't need to push them to 95, 96, 97. If you see a COPD patient starting 100%, something is wrong. In prioritization question, if they give you a patient with COPD, saturation is 88, 89, 91. Don't pick it as a priority. Your target is 88 to 92. Because if you give them too much oxygen, the oxygen will cause what? Oxygen-induced hypoventilation due to what? Taking the drive of their CO2. Most of their CO2 is what's driving them from breathing. And therefore, when you take that one away, they will have hypoxia. You need to manage their airway, and you need to teach them breathing technique. We'll go about each of them, what you need to do. But remember, emphysema, because of hair trapping, purse sleeping. In bronchitis, because of too much mucus, you do Huff cough to help them cough the mucus out. Forceful expiration using coughing 1 to 2 seconds to help with that. All of them need hydration, and then chest physiotherapy, especially for what? Bronchitis. Now, few of them. Medication. You already know. If you know asthma, it's the same thing. We have airway problem. We're going to give them bronchodilators. Albuterol, you can have short-acting and long-acting. Salmeterol, if you need more on the pharmacology aspect of it, check Adapting Class. But we give them bronchodilator. Ipatropine, right? Albuterol, there's some anticholinergic bronchodilators. That's ipatropine, right? This is ipratropium. And then we have bronchodilators, which are albuterol or salmeterol or formoterol. These are all bronchodilators. They need inhaled steroid to help with the inflammation. And you need to break down the mucus, especially acetylcysteine in what? Bronchitis. If they have infection, they get antibiotic. But the details of the pharmacology, check Adapting Class. I will link a video on respiratory pharmacology to this. So check it out. It will show up on the screen. Now, what do? Breathing technique, like I told you. Pursed sleeping, whistling for what? Emphysema. Because of air trapping, you want to extend your aspiration compared to the inspiration. But in a bronchitis, too much what? Mucus, you got to do Huff coughing. Now, complication. Let me explain this. They're going to have respiratory failure. It happens if they have upper respiratory infection. This is the reason why we tell them to get their immunization. This is number one. COPD patient has exacerbation. It can lead to respiratory failure. They already having what? Hypoxia. And therefore, when they have infection or any exacerbation, they have severe hypoxia, decreased oxygen, and that can trigger respiratory failure with their CO2 increasing more than 60 and a PaO2 less than 60. So this is a bigger problem. Think about it. They already have hypoxia. In the process, what is going to happen? Hypoxia is a stimulant of pulmonary constriction. So in the lung, the vessels get constricted. There's like obstruction, but no true obstruction. We have pulmonary constriction. The right side of the heart is supposed to push blood to the lung. If there is pulmonary obstruction, the right side cannot push blood to the lung. You have right-sided heart failure. Therefore, severe COPD and a right-sided heart failure is something we call pulmonale. So this is the basics of what? Pulmonale. You have right-sided heart failure due to severe COPD, due to what? Bronchoconstriction and what? Obstruction of the what? The vasculature, pulmonary vascular resistance, and they have right-sided heart failure. We describe polycythemia vera, the same hypoxia, oxygen level low, telling the kidney, I need what? Red blood cell. Therefore, secrete hypothene, which go to what? Your bone marrow and increase your hematocrit. This can lead to what? Stroke. This can lead to DVT. This can lead to pulmonary embolism. So polycythemia vera is an indication of severe hypoxia. Of course, recurrent infection is common. This is all makes sense when we tell them what? Get immunization. For the NCLEX, this slide is very important. So know it. Stop the video, put down this comment, and remember them. When they give you a COPD patient, what are you looking for? This is NCLEX. Key about all the video, all the information I've said, this slide is very, very important. Think about it. If the patient is very thin and he's doing pursed sleeping, no, that is emphysema. If they have productive cough and they blew cyanosis, think about bronchitis. And then the saturation, if it's greater than 92%, we are having problem. Keep them 88, to 91. If you start going more than 92, 93, 94, 95, 100, you're taking their drive, and that is the danger zone. So pay attention to oxygen supply. Now, let's put everything together that you've learned. You know how to do select or apply. Don't over-select. Pick those that you are 100% confident. Read the question from the back. What is the question asking you? Select or apply. Okay, what do I have? Which finding should the nurse expect? Expected finding. That means I want to make sure this is an expected finding about what? The nurse is caring for a client with chronic bronchitis. It's a COPD. Go to the pathophysiology. You know what is the pathophysiology. Stop the video, put down your answer in the comment, and let me know about it. But you know, these people, we have inflammation, mucus secretion, airway obstruction due to what? Fibrosis. Therefore, what should I expect? You're going to cough from excessive secretion. Your chest is not going to get big because you don't have too much hair trapping. This is what? Emphysema. Because you have obstruction and you have chronic obstruction from the airway, you turn blue, cyanosis. Due to hypoxia, you're going to have Polycythemia vera. They are not thin, they are not cathetic, they are usually obese, and therefore this is wrong. This is what the NCLEX will give you. Know them in terms of select and apply and master them. So A, 1, 3, and 4 are your right answer. Did you get them right? I hope so. Number 2, same strategy, select and apply. Which assessment finding are expected? When they give you COPD patient, trust me, this is what they're going to ask you. An expected finding because they want you to compare bronchitis and emphysema. And then it's assessing a client who has emphysema. How are they giving you the pathophysiology? The major problem, alveolar distraction. We have recoiling problem. The alveolar get bigger, and they develop bullae. They're going to perforate. That means pneumothorax. Therefore, which one? We're going to perslip, right? Our AP diameter is going to increase. We don't have excessive mucus secretion. We're going to use our accessory muscle. We don't have recurrent lung infection due to lack of mucus secretion. 1, 2, and 4 are your right answers. I know you get that one too. Number 3, which intervention promote airway clearance? The key word is airway clearance. What? For a patient with COPD, that means we're thinking about there's mucus there. If there's no mucus, we want to open the airway anyway. So airway clearance does not matter whether you have secretion or not. So far as you think we open the airway, we're good. Encourage off coughing, limiting fluid intake, administering bronchitis, administering bronchodilators, teaching pursed-lip breathing, providing chest physiotherapy. Which one will improve that? Well, you know, if I'm half coughing, I'm clearing secretion. So that's good. If you limit fluid intake, you cannot clear your secretion. Administering bronchodilator is going to open the airway. Teaching pursed-lipping is for what? Prevent air trapping. It's not clearing secretion, right? The word clearance, airway clearance. Providing chest physiotherapy is going to help clear your airway. Therefore, 1, 3, 5 are your right answer. Did you get that right? I hope you did. Based on the content, you should be able to do that. And this is teaching about the disease process, select or apply, which statement indicate understanding. And this is teaching the client about COPD, about oxygen therapy. Bad problem. You got to teach them to know when to use oxygen, when not to. I should keep my oxygen flow rate low. Is that appropriate? My oxygen saturation goal is 88 to 92. Is that appropriate? Too much oxygen can reduce my drive to breathe. Is that appropriate? I should increase my oxygen if I feel short of breath. Do you think that is okay? High flow oxygen is safe for a long term. What do you think? This is oxygen therapy. Like I said from the introduction, if you know oxygen therapy and the limitation, you know COPD. Yeah, keep it flow low. Your saturation range is perfect, nothing more than 92. Too much oxygen can reduce my ability to breathe. Excellent. It take away your drive. I should increase my oxygen if I feel short of breath. If you feel short of breath, that respiratory failure, increasing your oxygen more may worsen it. It's a trap. High flow oxygen is not safe for long term. It's usually used for short term. 1 to 3 is your right answer. What is your score so far? Last one. I know you get this one too. Which findings are consistent with this condition? Selected apply. And this is reviewing ABG results for a client who has what? Advanced chronic bronchitis. What should you expect in a COPD patient who has chronic bronchitis? You know about their oxygenation. Is it decrease? Is the CO2 increase? Do they have respiratory acidosis or metabolic alkalosis or normal oxygen saturation? What do you think? What do you think? They have hypoxemia. Therefore, if you have hypoxemia, you're going to have decreased oxygenation, and therefore PO2 is decreased. They have respiratory acidosis, retention of CO2. Excellent. And this is consistent with respiratory acidosis. They don't have metabolic alkalosis, and your oxygen saturation is low, 88 to 92. Therefore, 1, 2, 3 are your right answer. There's a COPD, pathophysiology, mechanism, teaching, pharmacology, and of course, selected apply 5 questions to synthesize the difference between emphysema and bronchitis. Thank you for watching, and this video help you. Just put a little bit of comment in the comment section and give us a thumbs up so that we can grow this channel. And good luck. And like I said, check on the screen. The next video, we'll talk about pharmacology, about COPD patient. And if you need more, check out SATA NCLEX for content like that. Good luck, best of luck, and take care of yourself.